Hi, I'm Mary Sue Rominger, and I'm a volunteer here at the Bateman Horn Center. Welcome, and thank you so much for joining us tonight. We will post a video of tonight's presentation on our YouTube channel within a few days, so if you missed something or want to hear the presentation again, you can go to the video and do so. We do plan a Q&A at the end of the presentation, so if you will hold your questions till the end, that would be appreciated. And those on Facebook Live, you can use the comment section to ask your questions. We are so pleased tonight to have Dr. Lauren Johnson speaking at our education meeting. Dr. Johnson graduated from the University of Utah with a Doctor of Physical Therapy degree and a bachelor's degree in exercise science with a minor in nutrition. She is currently the director of the Pelvic Physical Therapy and Wellness Clinic here in the Salt Lake area, and she also serves as a board member of the student-run pro bono physical therapy clinic at the University of Utah. Her passion for pelvic physical therapy developed back when she was a physical therapy patient herself. And she will be talking tonight about getting to the bottom of pelvic health. Please welcome Dr. Lauren Johnson.
Okay, so thank you so much for having me. I'm really excited to be here, and I'm really excited about this topic because a lot of people don't know or understand what it is. So I'm going to be discussing kind of pelvic health in general, and specifically pelvic health physical therapy, and how it can relate to ME/CFS and fibromyalgia. So to begin, my kind of learning objectives and what I want people to understand from this presentation is what is pelvic health physical therapy? Who are pelvic health physical therapists and what are our certifications, kind of what diagnoses we see as pelvic health physical therapists, what to expect when you're seen by one of us, because sometimes that can be a little bit intimidating, wondering what's going to happen, and then know kind of the association of pelvic health with MFC or ME/CFS and fibromyalgia. So to begin, it's always interesting to kind of take a poll of how many people even knew that pelvic physical therapy was a thing. Okay, so a lot of times people will come in and see me and they say, I had no idea you even existed. I had no idea that you were even a profession. I had no idea that physical therapists kind of specialized in the realm of pelvic therapy. So I like to tell people it is just like other physical therapy. We work with muscles, bones, tendons, ligaments. We work to rehab them. The only difference is it's in a little bit of a more sensitive area of our bodies, and there's just high emotions tied to this region. So, what is pelvic health? There are three systems, physiological systems in the pelvis and the abdomen, and they are the reproductive system, the urinary system, and digestive system. In order for us to have optimal pelvic health, these systems have to be kind of integrated and working cohesively. So, my job is to make sure and help that those systems are working together and find any dysfunction that's occurring. They are kind of housed within our abdomen and our pelvic region in the musculoskeletal system and the nervous system. So there's a lot of things that can be happening in this region and in our bodies to be causing dysfunction. And so we try to find sources physically that might be causing any of the dysfunction that we're finding. So who are we? How do we become a pelvic physical therapist? So you might hear us be called different terms. There's pelvic health physical therapy, there's pelvic physical therapy, and then the oldest term is kind of women's health physical therapist. But our association has quickly understood that women's health physical therapist is kind of eliminating half of the population, because men have pelvic floors, men have other functions or dysfunctions that can occur in the pelvic region as well, and so they're working to change that name currently. So we graduate from accredited doctorate of physical therapy programs. So we go through an undergrad, and then it's a 3-year doctorate program. After we finish that 7 minimal years, then we go on to postdoctorate specialized training. That can go from years to a whole lifetime of training. You hope that your pelvic therapist has a passion in order to continue to stay on top of the most current education and research. And then we can sit for a certification. So 2 of the certifications that we have is Women's Health Certified Specialist and Pelvic Rehabilitation Practitioner Certification. That really lets you know that that therapist has really specialized in pelvic health physical therapy. And it is very, very, very important that if you're going to be seeing someone for these conditions, that they have these certifications or these specialists or specialized areas so that you know that you're going to be getting the best care. Ways that you can do that is Herman and Wallace is one of the institutes that provide a lot of our continuing education courses. We have our American Physical Therapy Association, so they're nationally kind of our institutes, and there are ways of finding people or therapists in your area for that. And then you can always ask local clinics here. Most everyone knows, all the physical therapists know kind of who the pelvic floor physical therapists are, because we're kind of limited. There's not many of us, so most people know what's happening and where we're located. So what do we treat? This is just a small list of what we do and treat. A lot of people are a little bit surprised to name kind of the most common things that we see. We see incontinence, we see constipation and irritable bowel syndrome. We have interstitial cystitis or bladder pain. We do penile neuralgia, dyspareunia, so any pain with intercourse, tailbone pain, chronic pain, endometriosis, any pelvic girdle joint pain that's occurring, vulvodynia, vulvar vestibulitis, pelvic organ prolapse, separation of the abdomen that normally occurs with pregnancy, any pelvic pain, both men and women, chronic prostatitis, erectile dysfunction. We work with scar tissue mobilizations and management there, and then pre and postnatal care. So pretty extensive, but then there's even more than what we treat. So the most daunting thing is, what are you going to expect coming and seeing a pelvic floor physical therapist? Okay, a lot of people are like, I know where you work, so what does this entail? So I want you guys to have a very comfortable idea of what you should expect when you come and see one of us and what should happen. So the basics are, you're going to come for an evaluation. We'll then examine you. We'll hopefully, if you're going to someone great, they'll educate you on what they find and maybe reasonings behind that. They'll then jump into treatments. They'll give you a plan of care, a home program, and then eventually be discharged. So the biggest thing is, do not be nervous. Again, we are like other physical therapists, we just specialize in a more sensitive area. So the evaluation, this is critical. We want to know who you are. We want to know your story. We want to know everything you've been through, because what you say will give us the big picture of what's happening, what your body has gone through, what your body's currently experiencing, where you are, and then how emotionally that is being portrayed. So we're going to ask your symptoms. How long have they been happening? How intense are they? Where are they? What makes them worse? What makes them better? You know, what medications are you on? Have you noticed any side effects from those? Surgeries and procedures, right? What have you tried? What have you attempted? What have you diagnostically been through? And what do they know that's going on? What do they not know what's going on? What is your lifestyle, right? We all have lifestyles, and there's postures that we're in consistently. There's movement patterns that we get into because we might work in a warehouse. We're constantly lifting and twisting. You know, what's going on? Are you pretty sedentary because of fatigue and pain? You know, those are all kind of behaviors that then present physically. And then what have you tried? And a whole slew of other questions. My biggest thing is my patients tell me their story, and they tell me exactly kind of what's occurring, and that really leads my treatment. So I try to get a really good picture of what's happening to give you the best individualized care. The next is examination. This is the part that most patients get anxious about, okay? It is really not bad. The number one thing is know you're in control. We should not be doing anything that you do not feel comfortable with. And the biggest thing is we want you to feel safe and comfortable. We want to remove any threats that you might be experiencing, because the body's going to respond if you do not feel comfortable and safe. But our whole goal is that we're going to look at your anatomy, both externally and internally. And I know the internal part is the intimidating part, but it really is not bad. We want to look at your abdomen, your trunk, your pelvic floor muscles, the lower extremities. What's happening? Are there tight muscles? Are there tissues that are irritated? Is there scar tissue? Is there posturing that's occurring, right? Then we're going to look at how you move. What seems very functional and what seems dysfunctional to us. Why did you develop that pattern of dysfunction? Was it because you have pain on your left hip, so you don't want to sit on that side, so you're always sitting to this side, which then causes your trunk to rotate this way, right? We look at why these things are occurring, and then we want to know what causes your pain and what relieves it. So we might try some different tests and measures and see, is this painful? Yes or no? Is that relieve your pain? Yes or no? This gives us a really good big picture of what's occurring. The next part is education, okay? Knowledge is power. I want you to know what's going on with your body. I want you to know what I find. You knowing why these things are occurring are going to help you change any habits or patterns that might be occurring. So I'll tell you what I found with your anatomy. Were there tissues that were tight and tense and causing pain? Was there a joint that seemed to be too unstable or stuck and not moving properly? Does it seem like every time you go from a sit to stand, you kind of always lean to your right? There's all of these functional and habitual movements that I might find. And then how is your body making compensations or modifications for these things? When our bodies are extremely smart and intelligent machines, but they often will compensate to just keep us going and doing what we need to. And we often push through pain. We push through a lot of things, and our bodies do that, but it will compensate in some way, and eventually it usually develops pain. And then we'll teach kind of techniques. What are we going to do, right? The other thing is I want you to have a big comprehensive treatment. I don't want to be the only healthcare provider because there's so much going on with people's overall health. So based on what I find, what you've told me, I might find it necessary to refer you to physicians, nutritionists, psychologists, sex therapists, or any other healthcare provider that I feel like will give you a bigger whole picture and better healthcare treatment. So treatment itself, I'm going to just briefly skim over these because we're going to go into a little bit more in depth later in my presentation. But the big ones are kind of manual therapy. This is where we kind of have hands on you. We are doing some soft tissue mobilizations. We might be mobilizing a joint to get it to move better, or teach it how to move again because it's learned to be like move in a awkward pattern or position that's not cohesive to the joint and how your muscles and bones lie. We use kind of dry needling, and that seems a little bit intimidating, but there's been huge research and success for chronically ill and chronic pain patients. We're going to teach you exercises. Now, again, we're not going to go out of the limits of your body. Some people have been told that they feel like a physical therapist stands for pain and torture. Okay? I'm sure some of you guys have experienced that. But our goal is that it's pain-free. Okay, so anything that we give you, mobility-wise, strength-wise, endurance-wise, should be pain-free and it should be tolerable. We'll get into that more later on. Therapeutic activities, right? We teach you techniques on how to be functional. Maybe you need to compensate in some ways in order to do certain activities around your home. We'll teach you how to do those. How do you conserve energy doing those things so that you can do them? And then the last is neuromuscular re-education. This is, does your body know where it's at? Does it know how it's moving? Are you aware of what's happening internally? Is there coordination there? So the plan of care is pretty basic. Hopefully the therapist will then tell you what frequency they want to see you and the duration. Now that can change and adapt based on how you respond to treatments. The biggest thing is this should be both the physical therapist and the patient involvement, right? If you feel like they want to see you 3 times a week, but that's going to completely exhaust you, you need to vocalize that, right? You know your body better than that therapist. So let them know what you feel like is doable and not. It needs to be a cohesive and a joint effort between the therapist and the patient. And then they're going to give you a home program. And again, we'll go into all of these a little bit later when we get into it, but it should include kind of mindfulness of your body, pain reduction techniques, exercises, mobility, to just kind of help you keep moving. And while you're not with us, that you're kind of continuing a program. The last is our ultimate goal is to discharge you, right? We end up loving our patients, but we still want you to be able to do this independently and on your own. We want you to have a good quality of life, and we want you to feel like you have improved function and you're able to do the things that you love and you desire. And how you end up doing that is by continuing usually your home exercise program to at least maintain where you've been, but most people continue to progress even after they've been out of therapy. So what? What does this all mean now, right? How does this even correlate to ME/CFS and fibromyalgia? So I want you to look over this list again and pinpoint, what are you experiencing? There might be 1 on here, there might be 7 on here, right? There's a lot of these diagnoses that have been related and correlate with chronic fatigue. So they don't fully, when looking at research, they don't fully know the exact numbers, okay, and understand the relationship between chronic pelvic pain and fibromyalgia and ME/CFS, but they know there are higher rates. So some of the statistics that we were able to find, okay, is that there are pelvic conditions that are significantly higher in this patient population compared to controls who do not have these syndromes going on. So one of them is women with ME/CFS are 4 times more likely to have a hysterectomy. That's pretty high. Okay. Then the average age of menopause for, again, ME/CFS women was 10 years earlier than the control. We know that there are a lot of side effects from going through early menopause, and so that can kind of cause some effects in the long haul. Men with ME/CFS are 2 times more likely to have chronic prostatitis. And then men with ME/CFS have 2 times higher risk of developing erectile dysfunction. So that is just a small snippet of what I've found, but there's so much more out there that there are higher prevalence of pelvic health issues in people with ME/CFS and fibromyalgia. And then chronic pain in and of itself, which many of these health conditions will produce pain, increases the symptoms, right, that you're all experiencing. So if we can help reduce the pain that is occurring in the pelvic and abdomen region, then we can reduce overall pain that you're experiencing. So one thing that we need to get into before we talk about treatment is kind of the pain cycle. Okay, there's neuroscience about pain and what occurs in our body, and when we experience pain, what happens and triggers. It is a vicious cycle. So first off, the body experiences pain. There is a reactive, reflexive muscle spasm, right, and inflammation that occurs to that area that you're experiencing pain. Then that contracts those muscles, which puts pressure on the nerves. The nerves don't like to be squished, so it sends signals to the brain, there's pain, there's something wrong. Now the body reacts. Okay, over time the muscles tense and tighten. It creates imbalances. So say you have pain in your right hip. Well, your body's going to be contracting that side, so then your left side has to really compensate for it. There's reduced circulation and blood flow and all of these other things that occur. Okay, because of that, and like I said, our bodies are amazing machines. They're going to cope to keep you going. So how they do that is by compensating. It might be that you develop a limp on your left side because of the pain. It might be that you can't lift your arm this high, so then you're always reaching across your body, which then is causing torsion and tweaks through the back. In some way, it copes, but it's going to alter the joint mechanics and the joint position. Those altered joint mechanics and positions increase energy expenditure and consume your energy, so leading to more fatigue because it takes more for you to sit and stand than someone without pain or these coping strategies that your body has become accustomed to. Over time, those muscles shorten and weaken, okay, and then you lose function. You start saying, I can't do this anymore. I can't do that anymore. With that, the body just adjusts, and you almost get into a mental state where you feel anger, frustration, and hopeless. It is not fun. Then because of that, there's more pain that occurs. You stop moving as much, okay? It's called movement avoidance. You avoid certain movements. Because you're avoiding that, then more movement avoidance occurs. Okay, it's a cycle that occurs, and we've got to break it. And that's where us pelvic floor physical therapists try to step in, reduce these coping strategies that your bodies produce to help you live with better function and energy and reduce pain. So one thing so it's sometimes hard to kind of wrap your head around, but say I'm experiencing pain in my left hand. Okay, the body's initial instinct is let's not move that hand because it's painful. So my body will clamp it and close it. Okay, it doesn't want it to move. Well, in the long haul, if I keep my fist tight like this, it's going to become dysfunctional. It's going to start to hurt. I can't open it anymore. I can't use it to open a water bottle or to write or to open a door. Then, if we go in and we start trying to work on it, if I eventually get my hand back open through stretching, okay, and joint mobilizations, it's going to be weak because it's been like this for so long it doesn't know how to function. So then we try to get coordination back through those muscles, gain strength, and then move on to true function. So the pain cycle is really what we're trying to break. So what happens when we experience pain? Okay, our body goes into chronic holding and contraction of our muscles. So often with my patients who are experiencing pelvic pain, they have a non-relaxing abdominal and pelvic floor muscles, right? That causes pain, that causes trigger points. One thing is our bodies are much more protective over this area of our body because there's openings to our body, right? They know we're vulnerable. Our body does not want things to enter or exit that shouldn't be, that are harmful. Because of that, it is going to be much more protective in nature and much more reactive. So they're going to close and tighten much more quickly, and they're going to be slow to learn that things are safe again. The biggest thing is when you're in pain, what is the biggest thing you want to do? You want to curl up in the fetal position, right? You don't want to move. You want to protect yourself, and you don't want to have pain. So our body protects vital organs, so that's your abdomen and your pelvic region, much more strongly than other parts of our body. So you're going to get even more of a response in these regions, and also emotion is tied to here. So what effects do you have? Again, if you think of the fist, if you are having a non-relaxing abdomen muscles or pelvic floor muscles, okay, it's going to get tight and tense. There's going to lose mobility. You're going to lose your strength, so eventually you're going to lose function. And specifically in the pelvic region, that usually results in anything urinary, sexual function, and bowel function, right? So we'll go back to the list, but all of that list that you saw, that's all can be affected because of the pelvic floor muscles being too tight. So the muscles get tight and tense. It reduces your mechanical efficiency, which increases the energy needed to move. This can also then cause friction between the muscle and joint, causing pain. What happens when you're in pain? You activate the parasympathetic nervous system. Okay, that's your fight and flight. That is protect. That is close down and clamp, right? So we're trying to get out of that parasympathetic nervous system. That then increases more pain. Okay, then because of the tightness, you lead to incoordination and dysfunction of those muscles, which then affects the three systems that we talked about. And then it ends up with expending more energy. You end up more fatigued. So what do we do for treatment for non-relaxing pelvic floor muscles? The first one is breathing patterns. Okay, if you think about how you breathe, and if you take a second to take a nice deep breath, where are you feeling that breath? Is it all chest driven, or is it through your abdomen? Most people in pain do short chest breaths, short, shallow chest breaths. Our goal is that we bring that breath down into your belly and your pelvic region. There is a nerve that pierces through your diaphragm. So when you do diaphragmic breathing, it stimulates the vagus nerve. That is your parasympathetic nervous system. That is your rest and digest. That is getting you out of the sympathetic nervous system of the fight and flight. That overall can calm the body. That will reduce pain, but it will not eliminate it. So diaphragmic breathing, it also will increase oxygen and the energy available. So step one is look at your breathing, okay? No more short, shallow chest breaths. Nice, big, slow diaphragmic breaths. Calm the body. Mindfulness. Mindfulness is huge. How often when we're in pain do we want to check out of our bodies? Right? This body is not working how I want it to work. I do not like it. It is my enemy right now. I want to get out of my body. So often when we're experiencing pain, a lot of us check out. We say we don't want to experience this anymore. So I'm going to think about this now. I'm not going to think about that. But bringing yourself back into your body, being aware, recognizing where is this pain coming from? Why might it be coming? right? What can I do to do it? Am I tense and tight? That tense and tightness is going to lead to more pain. So instead, trying to relax and calm the body. Now, everyone is like, Lauren, relax. Everyone tells me that, relax, right? Way harder said than done. So we do guided down trainings to really teach you how do you do that properly and right, okay? It's not an easy task. Biofeedback. Does your body know what it's doing, right? There are times that I'm palpating a pelvic floor, right? And I tell them, relax. And they're like, I am, but there's no movement. Okay, that's because they have learned to be tight and tense. They might relax a little bit, and to them that feels relaxed. But really there's a whole new level of down training and relaxation that they need to experience. So can you be aware of that internally? Can you be aware of when your body's clenching and tightening versus when it's relaxing and softening? Okay, what is the difference between that? So there's EMG devices that read the pelvic floor muscles. There's external palpation that we do, but really kind of giving your body some feedback on what's really occurring, because you guys have probably been in these patterns for a long time, years and years and years. So you're going to feel like, well, that's normal. I don't know, that's normal, right? So we retrain how the body needs to function and move by giving you feedback. Manual therapy. Okay, we put our hands on you. We want to feel what those muscles are doing. Where are they tight? Where is it not moving right? There's so much with joint mobilizations, with soft tissue work that we can relax the muscle, teach those muscles how to move and glide, the joints, the soft tissues, the organs, right? Constipated patients, you get just so backed up. So we teach kind of GI mobility and massage. We get that stool to move. We get the bowels to be stimulated, so it does help with this whole process. There's a lot that we can do hands-on. And then mobility. We want the pelvic floor and the abdomen to move, right? Those areas need movement. Those organs are not meant to be squoze, right? They need to have movement and mobility. Now, we live in a world, though, that is a lot of appearance-based, right? No one wants to have a gut, so we all suck in. We want flat bellies. Well, what do you think that happens over and over, like with time, over and over by sucking in? That's kind of like putting a corset around your organs that need mobility and movement. So we teach that. Do you need to relax your abdomen? Do we need to relax the pelvic floor? Some people think they're constipated, but really they go sit on the toilet and the pelvic floor muscles are so tense and tight, you're pushing against closed door, right? You're trying to get that stool to come out, but the doors are shut. So how do you get the pelvic floor to relax and open in order for the stool to come out? That's some of the things that we can teach. And mobility is really, really key in our body. There's a really funny saying that they say, like, motion is lotion for our body. If we're moving and giving it mobility, it's happy. So a more general and broad treatment plan is, our step one is we need to restore range of motion. Okay, because of pain, we tense up and tighten. Because of that, you're going to have altered mechanics, altered energy expenditure. So we need to first restore normal range of motion. It needs to match your other side, right? We do that by the tension reduction techniques, mindfulness, breathing, possibly hands-on mobility work. If you have had abdominal surgeries or pelvic surgeries, there might be scarring. So we need to get in and move that scar, make sure it's mobile so it's not keeping things adhered to each other. Movement overall, some gentle stretching. It doesn't need to be painful. And then functional movements. What do you need to do throughout your day? Do you need to be able to unload your dishwasher? Well, how can we teach you to move in the most energy efficient and safe way for your body to be able to do that task, right? That might be the one task that you're able to do for the day, is unload a dishwasher. So we need to let you do that efficiently. Step two is then coordination. Once your muscles are moving how they should, we need to teach them how to coordinate and move again. After you've had trauma or tension of the muscles, they're going to say, I don't know how to work or function. So we retrain, we re-coordinate all of it. And it's done through several different steps. The last is strengthening. Sadly, there are too many physical therapists out there that's their first step. They think, you're weak, we just need to strengthen you. Okay? Well, because of the dysfunction that you're experiencing with the movement and the joint mechanics, you're going to be strengthening a dysfunction. Okay, we do not want to strengthen a dysfunction. So it needs to first range of motion, coordination, motor control, and then move into the last step of strength. So things to avoid, right, is this push-crash pattern. How many people are like, it's a good day today, so I'm going to do it all, right? Because the last 7 days were not good days. So you go, 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 and then you crash, right? We teach pacing strategies. You've got to remove stress and the musculoskeletal system. You need to have energy conservation. You need to only go as far as your body's going to allow. It's not fun to push that boundary and then be in bed, right? So we teach that. But the hardest thing is really coming to grips with where your body truly is. For some people, that is simply getting out of bed, right? Getting from your bed to the couch. That might be it. Your bed to the toilet. That is okay, right? That's where you're starting. We will then help you pace and learn how to be able to have more energy, get the body moving better so that there's better strategies. Okay, you want to not prevent movement, right? Avoidance of movement is a negative. It only leads to more avoidance. But it needs to be graded movement exposure. You need to learn that I can do this. That wasn't so painful. I could handle it. Slowly, 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 right? We expose you to more and more that your body can tolerate. And then we never want to impose a physical load on the body that it can't tolerate. That is when you're going to crash. And your body's going to say, no, I hurt, I'm in pain, I'm done. So my goals as a physical therapist is to make everyone's plan individualized, okay? If you are coming and I'm like, this is your protocol, and I give it to everybody, that's not going to be successful. I learned that by knowing your true story. I know that by examining your anatomy, knowing what's going on, okay? Looking at how you move, how you function, and really, where are you starting, right? We are so minimal, and we want the body to have success and to learn that these things are safe again. So very individualized. Okay, pain-free treatment. It should not be pain and torture. Pain-free. That will give the body a better experience, and it will not learn to tense and tighten and be in, again, that fight and flight. We want to re-educate breathing patterns and how you move, right? We want to make sure that you're moving in positive ways, in ways that the body is finding pain-free movement, that it doesn't feel like it's taking everything in you to do those things. We want to find that balance of the autonomic nervous system. We want to get you out of fight and flight. We want to get you in rest and digest, right? Get those signalings out to get the body to calm down. There's really good information on like neuroscience and pain neuroscience. We want to restore the healthy tissues for improved range of motion, mechanical efficiency, and energy proficiency. That's our goal. And then we want to overall just expand the person's functionality, right, and the loading on their systems. We want you to be able to do more of what you love and what you enjoy. And bottom line is we want you to be empowered, right? We want you to feel that these things are doable and that you're capable. And this isn't going to put you in bed for weeks on end. Okay, that is the biggest, biggest, biggest thing. And we want you to get back to what you love, right? We want you to have good, good, good quality of life. So that's kind of all the information. It's very much just an overview of what's going on. I didn't get into too much of the pelvic diagnosis and treatments. That can happen more if you choose to see one of us pelvic health physical therapists. This is my information, but then I think we'll open it up to any questions that might have risen.
I have a question. How long in general, and I'm sure this is pretty variable, but in general, how long does it take, or how long do you need to be in therapy before you see significant improvement?
So it's very much individual, like you had guessed. It all has to do with where the patient is starting. But honestly, within weeks, patients are feeling like they're able to do more, and that more might be simply doing one more activity for the day. But it does not take long as they're kind of following the instructions and we're finding ways of getting the body to move in a more happy and positive and pain-free way that people are feeling like they're able to do more than what they're doing. So I know that's vague because it's very individual, but it's not as long as you would think.
Yeah.
postmenopausal women who may be having, you know, like tissue degradation, hypersensitivity that prevents, for example, a medical examination?
Yes.
Would you be able to help with that?
Yes, we treat that all the time. So any pelvic pain that you're experiencing. So,
Excuse me, I'm sorry, we're not mic'd to hear the audience question. Would you mind repeating the question?
okay, yeah. So what was asked is, do I work with postmenopausal women who their tissue integrity might be a little bit low and sensitivity and pain that way? Is that correct?
Yeah, I mean, to the point where you can't have medical examination.
Yeah, to the point that you don't have medical examinations, and the answer is yes. So there's several reasons why you might be experiencing some of that. A lot of it is hormone driven, right? But because of that, the tissue of like the vaginal opening and the vulvar region become softer and more pliable, so they become more sensitive at the same time. So what we do is we work to see where are you kind of hormonally, right? But then we do some manual therapy through those tissues to allow them to stretch in a graded manner so that you're not in pain, and to become more pliable to then be able to tolerate a medical examination, maybe vaginal penetrative sex, right? Any of those other things that you might be wanting. But again, it's in a pain-free way. I think a lot of women get intimidated being like, oh, the last time I tried to go get a gynecologist exam, like it was not tolerated. So again, pain-free so that we don't send off that whole spiral and that pain cycle. But yes, we do work with, I work with women like that all the time.
Okay, thanks.
Mm-hmm.
So we do have a question. I'm going to stand up here, close to the mic. But the question is, would therapy possibly prevent the need for a bladder sling?
Yes. So you're probably referring to a bladder prolapse, okay? And you're referring to the surgery where they tack the bladder up in order for that prolapse to, the bladder to be sitting in a more neutral position. So again, it's variable, but there has been research to show that pelvic floor physical therapy can change the grade of prolapse by at least 1 grade. And then there have been over and over again where women were experiencing maybe stress urinary incontinence or pressure syndrome or symptoms down in the pelvic region. And with pelvic floor retraining, they're able to better give support to the bladder to prevent the symptoms that you're experiencing with prolapse, to ultimately like prevent surgery. So it's pretty incredible. And and then the other thing is, if you end up needing a surgery, if pelvic floor does not work, you end up needing a surgery, the results afterwards are greater and they last longer. Because often some people think you just have prolapse because you had babies, right? That's like the general idea. But you might be bearing down and straining and pushing, and what's happening in your abdomen? Are you tense and tight, leading to more pressure downwards? You might have a dysenergetic breath where you inhale, you actually bear down, and vice versa. So there's so many other causes and reasons that prolapse occurs. So you want to see a pelvic floor therapist to analyze that and to figure out what you're doing, so that if you ultimately do end up with surgery, that surgery lasts a lot longer. Because sadly, there's a 5-year failure rate for those bladder slings.
Oh, wow.
And you don't want to be doing that over and over and over again. It's not a fun surgery, for sure.
Yeah.
I have a question. Do you want to repeat it? Because it looks like our audience needs to have them repeated. We have a whole subset of illness for ME/CFS of those who experience IBS and other gastrointestinal issues. So a lot of our research is related to the microbiome. Can you talk about how your therapies, what you're talking about here, might help people experiencing IBS?
Yeah. So do I need to repeat that question, or was it heard?
No,
I think maybe just the IBS.
Yeah.
Okay, so how can we kind of help with constipation and IBS? So specifically IBS, I think, is a little bit more common. And what we look at, again, microbiome is a huge and upcoming research right now, and it's massive and big. And that's where we coordinate with physicians to see what's going on there. But what our goal is what might be happening mechanically, structurally with the bowels, okay? Is it because of tightness and irritation that's causing more inflammation? Is there a reason that the bowels aren't moving well, and so we need to get some myofascial releases of the bowels? We look at the stool, right? Most often it's too soft. So what are you doing diet-wise, right? What are you doing nutrition-wise? What is the consistency? How are you excreting that stool? What's happening? What's bloating? Most people, when you're bloated, you want to fight against the bloat, right? It's uncomfortable, so you tense and tighten. that causes more irritation. So instead learning to how, again, talking about mobility of those bowels that you get, is how do you get the abdomen to be mobile and moving. But we do work a lot more with dietitians, nutritionists, and physicians to find out what might be more of the cause and the reason behind that. There are also trigger points that happen through the abdominal muscles, so we're releasing those to kind of reduce pain and irritation from what's occurring because of the IBS and the bloating symptoms. So there's a lot there. Also, the pelvic floor, again, it's so funny that everything kind of ties back to a lot of the non-relaxing pelvic floor muscles. But when you're kind of worried about like, oh my gosh, like I have gas or I'm going to lose this bowel movement, you're constantly trying to contract to prevent that from happening. So then it leads to more dysfunction. So really learning how the reflexes of the rectum and how does we retrain that, right? To be able to know, like, is this gas stool, you know, what's happening here? So a lot of it is we look at the abdomen and pelvic floor and how are they functioning and how are they responding to the IBS, in addition to specifically let's work on the actual stool itself.
So another question on Facebook. Are there any discussion on creating an ME/CFS and fibromyalgia protocol to serve as a guide for physical therapists nationwide that you're aware of?
So there is, I cannot remember his name, but he is kind of working on research right now to really set like a very standard protocol for physical activity with this patient population. And what he's trying to do is he has you do certain activities and exercises. He's tracking your heart rate, your respiratory rate, and I think temperature of your body. And based on how you present that first day, then he very much does a graded exposure expenditure kind of log, and he'll give you exercises where you will be meeting those limits, and then he gradually progresses it. So there's just the beginning of that happening. I think what's hard about it is everyone is in such a variable place and starting point, but that's how he's trying to make it very standard by first doing that testing day one, finding out where you are and giving you your individual specific, like this is your heart rate zone, this is how much you should be exerting with your breathing, right? And so it's starting, but it's not full.
Could that be possibly the people at the Workwell Foundation?
I think
California?
so. Yep, yes it is.
So it's really helpful. I've had their evaluation.
Yeah.
It's helpful.
Yeah,
So
that honestly, that institute is wonderful.
Would you repeat the Workwell?
Yeah, so she brought up that it's the Workwell Foundation out of California, correct? And they're the ones doing it. So if you type that and Google that, he will pop up. His name is just blanking me right now. But there's a wonderful like short article about it, and he goes into it all. He also talks about like the activity pacing, that's where I got that like whole push crash, right? Protocol, all of those things.
Okay. Another question from Facebook. What does prenatal treatment include? Is it only recommended if we have pain?
Okay. No, it does not need pain. So very interesting enough, some of the prenatal work, is dealing with people with infertility issues even. So everyone thinks about what's happening hormonally, right? What's happening that like with maybe possible sperm. But we look at mechanically, what's happening with your organs itself. So during your monthly cycles, your organs should drop down lower to the vaginal opening. One is during ovulation because it shortens the distance that sperm needs to travel. The other is during menstruation, right? So that the lining of the uterus can be shed. So what happens, and maybe possibly in your cycle, you're not getting that movement for whatever reason. Maybe there's scarring. Maybe there's something else blocking it. So we look, how are the ovaries moving? How's the uterus moving, right? Are they dropping and moving? So we do some work with infertility work to determine that. The other thing is you don't need to have pain, but maybe just determining what is your pelvic floor and how is it functioning. You might deal with constipation, you might deal with urgency, you might deal with things like that, and then we will treat you through pregnancy. People are always surprised that there's a very specific way that you should push during delivery, right? People are like, what? Like people just tell me to push. But you need to push so that your pelvic floor is relaxed and the pressure's coming down. Because the pelvic floor does not like pressure. So when you're pushing, the pelvic floor actually contracts because it hates it. So you learn the proper push from the abdomen, but keeping the pelvic floor relaxed. So we really treat so much like prenatal, like posturing, right? How are you sitting? How are you moving? Then in your pregnancy, that is a huge change in how your body's moving because you're getting this belly, and so there's big strain on the back and the hips, and your hips are widening. So we teach you like how to keep stability through all of that, and then how to go into your delivery really, really prepared. And then more important, like not more importantly, but even more is postpartum, right? That is trauma, having a baby, especially like either vaginally or cesarean. And so I laugh and I get on a little bit of a soapbox that people come like after they've sprained their ankle, right? But people don't come see a pelvic or a physical therapist after they have a baby and like their whole pelvic floor is stretched and possibly torn muscles. Those muscles need to be taught how to contract again, when to relax again, to get motion and movement through there and learn to be functional again. So that whole process with being a woman, and if you go through that, I mean, it's vital to kind of be seen before, during, and afterwards to really make sure that you maintain as much function as possible.
That would have been helpful for me back in the day, in the very far back in the day.
I know, so many people are like, why did my gynecologist not tell me this? You know, what's funny is in Europe and a lot of the Scandinavian countries, it's mandatory. It's mandatory for women during that process to see a pelvic floor physical therapist. Slowly, it's becoming more and more known here in the nation. So,
do you work with gynecologists?
Yeah, I work with gynecologists all the time, and it's funny when they send their patients to me because they're like, you know, I don't know what this pelvic floor physical therapy is. I've had patients go and they kind of have success, like go see what you think. And then pretty soon more and more patients are going back to them being like, you need to send everyone. And so it's turned into like, you were a heaven sent for us. Like you get our women to stop peeing after they have babies, to have pain-free intercourse again, to be able to jump on a tramp, to be able to do all of these things that a lot of women see as now the new normal after having a baby. Which that is not normal. It's common, but it shouldn't be the new norm. Those things are all, it's all possible to have a rehab in order to fix those things.
That's wonderful.
Yeah.
All right, any last questions? All right, well, I think we'll wrap it up. Thank you so much.
Thank you. It was a pleasure, really.
This was just really valuable information, and I know there were several of us talking before your presentation about how we didn't even know that there was such a thing as a pelvic physical therapist. So this has been really good information and eye-opening, and I know this will help a lot of people. So we appreciate it. Thank you.
It was really a pleasure to be here. Thank you.
Thank you.
Thank you.